Hello everyone. This video is also regarding the disorders of kidney and urinary tract. And one of the major questions are asked in this topic is about the urinary tract infection in the children. And in most of the question papers, we were seeing that there will be the question regarding the investigations and management of the urinary tract infection of children is the most common question. So we will be discussed this in detail. So about the introduction, urinary tract infection is not just an infection, it can have far reaching consequences in the child. A large number of children with the first episode of UTI have the underlying basic urinary reflex, chronic or recurrent pyelonephritis, hypertension, and end stage renal failure. This is frightening list is just some of the outcome of an improperly treated UTI. That is, if we treat the UTI very improperly, we have the certain complication develop like chronic or recurrent pyelonephritis, hypertension, and end stage renal failure. So it is a very important infection in the case of children. So about the definition, urinary tract infection is the presence of any bacteria in the urine is called the urinary tract infection. And the cystitis, that is UTIs restricted to the bladder, is called the cystitis. And the UTIs which affecting the kidney, it is called the pyelonephritis, and it carries the risk of renal scarring, hypertension, and renal failure in the long term. And the recurrent UTI, a single further infection by a new organism is called the recurrent UTI. And relapsing UTI, further infection with the same organism is called the relapsing UTI. So another some more terms are like significant bacteriuria. The colony count greater than 10 raised to 5 per ml of single species in midstream clean catch sample is called significant bacteriuria. And the asymptomatic bacteria, significant bacteremia in the absence of symptoms of UTI is called the asymptomatic bacteriuria. So that is all regarding the definition of the UTI. Then when to suspect the UTI in the children. That is, what are the clinical presentations a child is present with the UTI. So infants which are present with the fever, vomiting, lethargy, failure to thrive, shock and signs of sepsis. And the older children may present with the dysuria, frequency, urgency, abdominal pain, fever with rigors, and recent onset of enuresis. That is, more urinary symptoms are in the case of older children. All the young kids with the fever of unknown origin should be investigated for the UTI. So that is all. Then also, if the asymptomatic bacteriuria is present, that is less than 1% of cases, significant colony forming unit of a single species on two occasions in asymptomatic patient, and is usually harmless and no treatment is required in the case of asymptomatic bacteria. So these are the clinical presentations we should suspect the UTI in the children. Then how to confirm the diagnosis of UTI? That is, how will you confirm the diagnosis of UTI? We have to go for urine routine microscopy, commonly done and gives presumptive diagnosis about the UTI. And it is a poor tool to diagnose UTI. The proteinuria is mild, greater than 5 WBC per high power field in centrifuge urine. And the urine, we have to go for gram stain also for the detection of the organism. Then gold standard is the urine culture is the gold standard for the detection of the UTI. Before antibiotic treatment, we have to go for urine culture. A clean catch midstream urine sample after cleaning the perineal and genital area should be taken. It is an ideal method, but not practical, and is a suprapubic aspiration is used usual. Then that is an ideal method. Generally, for infants, best is suprapubic aspiration, and for the older children, best is clean catch midstream urine sample. And urine, if not sent to the laboratory within 2 hours, we can be stored effectively in the refrigerator for the 72 hours. And what are the interpretation of the urine culture? Greater than 10 raised to 5 colony count of single species is 90 to 95% of probability of the infection. And 10 raised to 1 to 10 raised to 4 colony forming urine is significant in a patient on antibiotics. And organism on the urine culture and the clinical significance are E. coli is usually in the 70 to 75% of patients, and the Staphylococcus aureus can be found in this urine culture in about 5 to 20% of cases. That is more in the adolescent girls. Protease is used is a organism behind the formation of renal calculi, and the Pseudomonas in the case of nosocomial instrumentation, Candida due to contamination unless two positive Candida cultures, multiple organism, if there is any faulty technique will be that multiple organism can be found out in the urine culture. So that is the gold standard for the diagnosis of the UTI, that is the urine culture. The newer tests are the nitroreductase and the leukocyte esterase. The non-specific tests are the CBC and CRP and DMSA scan and detective for the detection of the pyelonephritis. So that is all regarding the investigation. And we have to also go for the imaging studies also, that is used in the first UTI attack. If the child is less than 1 year, we have to go for the USG abdomen and DMSA scan and VCUG. And in the 1 to 5 years age, we have to go for the USG abdomen and DMSA scan. And we can go for the VCUG if DMSA or USG is abnormal. Then about the greater than 5 years of child, we have to go for USG abdomen at the imaging modality. Then if the USG or the if the DMSA or USG is abnormal, we have to go for the VCUG, that is voiding cystourethropy. And this voiding cystourethropy is to detect the vesico-urethral reflex, and DMSA scan is used for the detect the renal scarring. So that is all regarding the imaging modalities in the first attack of UTI. Then newer imaging modalities are the direct radionuclide cystourethropy and enhanced cystosonography to detect the vesico-urethral reflex and for the follow-up. Then what are the treatment? The treatment is also asked as a question in the university exam. Treatment for the UTI aim is to prevent the renal scarring, to prevent the complications and recurrence of UTI. Empirically, we can that is before the cultural and sensitive report, we can use cephalosporin, that is example cefixime, or quinolone group example ofloxacin and ciprofloxacin. Simple UTI and patients above 3 months of age can be treated with the oral antibiotics. Parenteral antibiotics, if the pyelonephritis or less than 3 months of age, we have to go for the parenteral antibiotics like cephalosporin plus aminoglycosides. Then definitive treatment once a urine culture sensitive report is available, then culture sensitive antibiotics for the 7 to 10 days. Duration of treatment is 10 to 40 days for the infants and children with complicated UTI. We have to, along with this antibiotic therapy, we have to give supportive treatment in the form of maintenance of the hydration and IV fluids if sick febrile child with poor oral intake. Alkalization of urine is not necessary, and paracetamol for the fever. So these are supportive treatment for the urinary tract infection. And also then about the some important question about the prevention of UTI. The prevention of UTI is important as recurrent UTI predisposed to renal scarring. So we have to go for UTI prophylaxis. The indication for the UTI prophylaxis are first is the vesico-urethral reflex, then less than 3 years of age with the first attack of UTI pending investigations. The children with antenatally diagnosed renal anomalies causing vesico-urethral reflex, example hydronephrosis due to the posterior urethral valve or pelvic urethral obstruction. In these all cases, we have to go for the UTI prophylaxis. The drugs for the UTI prophylaxis is called cotrimazole 2 milligram, trimethoprim, and 10 milligrams sulfamethoxazole. That is cotrimazole is a combination of trimethoprim and sulfamethoxazole. So we have to give that. Then nitrofurantoin 1 to 2 milligram per kilogram single night dose. And we have to go for cephalaxin 10 milligram per kilogram single night dose, especially in less than 3 months of age. And how long we have to give? That is in the grade 1 and 2 vesico-urethral reflex, we have to give UTI prophylaxis up to 1 year of age. And the vesico-urethral reflex grade 3 or 4, we have to give this prophylaxis till the vesico-urethral reflex resolves naturally or till 5 years of age in operated patients for 6 months following surgery. And in this UTI prophylaxis also, we have to go for follow-up, that is urine culture sensitivity every 3 months for the 1 to 2 years, and 33% infants with UTI have the recurrence within 2 years. So that is all regarding the urinary tract infection. We discussed about the definition. And we discussed about the clinical features, investigation, management, and the UTI prophylaxis detail. Another short note is based on the cryptorchidism. It is also asked as a short notes in our university exam about the cryptorchidism. It is also known as the undescended testis. Cryptorchidism, undescended testis, is one of the most common birth defects of the male genitalia. So it is the most common birth defects of the male genitalia. So as an introduction, we have to write like that. Cryptorchidism, that is also known as the undescended testis, is one of the most common birth defects in the male genitalia. True cryptorchidism is defined as testis which cannot be brought down into the scrotum without undue tension. So usually the testis we have to be descend down into the scrotum, but in certain conditions, that is as in birth defects, the testis is not descends into the scrotum. So that results in the abnormal position of the undescended testis, also called the cryptorchidism. There will be classification of the cryptorchidism. That is, there will be true cryptorchidism, retractile testis, and ectopic testis. True cryptorchidism, which means there will be that is intra-abdominal peeping, that is abdominal, but can be pushed into the inguinal canal. Inguinal gliding can be pushed into the scrotum, but retracts to pubic tubercle. So these are the true cryptorchidism. Then retractile testis can be brought down to base of the scrotum without tension. So that is called the retractile testis. Ectopic testis is femoral, pubic, perineal, and trans-ectopic testis is called the ectopic testis. That is in the testis is not in the scrotum, it is in the other spaces like a femoral, pubic, perineal, and trans-ectopic. So that is about the classification of the uh, cryptorchidism. So when a short note is asked regarding the cryptorchidism, we have to write the definition, then classification, then about the pathophysiology, and how will you diagnose and treatment of the cryptorchidism. So the next heading is regarding the pathophysiology, the descent of testis into the scrotum, which occurs due to an interplay of the numerous number of factors, including testosterone, dihydrotestosterone, and Muller inhibiting factor, and also gubernaculum, intra-abdominal pressure, and genitofemoral factor. Now, it is also contributes to the descent of the testis. And the causes of the undescended testis is not known. There are some of the risk factors for the development of the cryptorchidism is there, like low birth weight and preterm, maternal exposure to estrogen in the first trimester of pregnancy, multiple births, androgen insensitivity, and malformation or the anatomic obstruction of the inguinal canal. So these are the risk factors for development of the undescended testis, but the cause is unknown for the undescended testis. The clinical implications of the undescended testis is poor testicular growth, infertility, testicular malignancy, hernia and torsion of cryptorchid testis, psychological effect of empty scrotum. So these are the clinical implications of the undescended testis. That is a patient present with these symptoms or these features. Then how will you diagnose a case of cryptorchidism? Testis should be palpated for quality and position at each birth by a two-handed technique, one hand on the hip and second sweeping along the inguinal canal. Infants with undescended testis up to 6 months of age should be evaluated further. Patient with the bilateral non-palpable testis should be evaluated for the DSGs and especially congenital adrenal hyperplasia. Then patient with the cryptorchidism with the hypospadia should be evaluated for the DSDs, and ultrasound or other imaging studies should not be performed for the cryptorchidism alone, as they do not aid in the decision in making. They may be done as a part of difference in sex development evaluation. Patient with the retractile testis should be evaluated annually to look for the secondary ascent. Then about this, so these are all regarding the diagnosis of the cryptorchidism in the child. Then about the treatment, hormonal therapy should not be given to induce testicular descent due to the lack of response. In the absence of spontaneous descent by 6 months, we have to go for the surgery. That is, in the undescended testis, if it is palpable, we can go for the open orchidopexy, 6 months to 1 year. Then if it is unpalpable, that is confirmed by the EUA. So we have, if it is unilateral, we have to go for the laparoscopy, and if it is bilateral, we have to go for HCG challenging test, and we have to go for laparoscopy. And by the laparoscopy, we have to go for open orchidopexy, laparoscopic orchidopexy, and the staged Fowler Stephen surgery. So that is all regarding the cryptorchidism. So in the absence of spontaneous descent by 6 months, we have to go for surgery. This is the surgery for the undescended testis. That is, if it is palpable, go for the open orchidopexy. If it is non-palpable, we can different options like open orchidopexy, just if the testis is just inside the internal ring, and laparoscopic orchidopexy if there is less than 2 centimeter from the internal ring, and staged Fowler Stephen surgery if it is greater than 2 centimeter from the internal ring. So that is all regarding the chapter of disorders of kidney and urinary tract.